arachidonic acid metabolites. So these arachidonic acid metabolites are potent, they are short-lived inflammatory mediators, and they are derived from membrane phospholipid through the action of cellular phospholipase. So these phospholipases are going to break down those membrane phospholipid, and they're going to release this arachidonic acid metabolite from them. And they are going to be, so where are they stored and released? So like we said, they are going to be released from the cell membrane. So the cell membrane content, as we know, our cell membrane are made up of phospholipid. So this phospholipase A2, so phospholipase is going to break down those phospholipid and is going to release this arachidonic acid from them. And that's the one of the drug that normally inhibit that phospholipase A2 is going to be corticosteroid. So that's why when you give corticosteroid, that could shut down this arachidonic pathway, thereby decreasing the production of those metabolites. And that's why if somebody is having a form of allergic reaction, right? One of the medication that we use for allergic reaction, particularly the histamine mediated, we use what? Corticosteroid, because we know that the corticosteroid will inhibit phospholipase A2, and that could decrease the production from this arachidonic pathway, and also decreasing the release of chemical mediators from the mast cells, from those inflammatory cells. So when we look at the arachidonic pathway, there are two major pathways here, So we have our cyclooxygenase pathway, and we also have the lipoxygenase pathway. So as we can see here, so we can see from the cell membrane phospholipid, the phospholipase A2 is going to work on it, and that will lead to release of arachidonic acid. And this arachidonic acid has two fates. It could go into production of our leukotriene, right, by the help of 5-lipoxygenase, or it could go to production of prostaglandin by the help of cyclooxygenase. So as you can see here, so let's start with the cyclooxygenase pathway. So as you can see here, so the arachidonic acid by the help of cyclooxygenase is going to form prostaglandin, and then this prostaglandin could now be could further be converted into different products from in this pathway. So the first one there is going to be prostacyclin, which is PGI2. So this prostacyclin normally causes vasodilation, and it also inhibits platelet aggregation, so it prevents the platelet from aggregating. And if the platelet does not aggregate, that means you cannot form blood clots, so that could decrease the formation of blood clots. As opposed to the next one, which is thromboxane A2, which the function is opposite to what we see with prostacyclin. So the thromboxane A2 normally causes vasoconstriction, and that normally stimulates platelet aggregation, and that's important in formation of blood clots. And that's why if a patient is coming in for chest pain, and if we are worried that this patient is having heart attack, right, one of the medication we give is aspirin, because we know our goal is to use that aspirin to decrease the production of that thromboxane A2, thereby inhibiting those platelet aggregation and preventing the growth of those blood clots. And the last one there is going to be the rest of the prostaglandins. So there we have the prostaglandin E1, E2, and the E2 particularly could cause pain and fever. And then this prostaglandin E1, E2, they could also cause vasodilation. And then remember, they also keep the ductus arteriosus open, right? And the next one there is PGF2 alpha, and this is responsible for dysmenorrhea. So dysmenorrhea, painful menstruation. So this is what's responsible for it. And the last one there is PG. So both PGE2, PGE1, and a PGF2 alpha, all those three, they could increase the uterine tone and contractility. So now moving on to the lipoxygenase pathway. So here we're going to produce our 5-HPETE, and this could be further converted into lipozyme. So we have lipozyme A4, lipozyme B4, and these guys inhibit neutrophil adhesion and chemotaxis. So that means they have anti-inflammatory properties. So they have anti-inflammation. And then we also have leukotrienes. So under leukotrienes, we have the LTB4, which normally increase neutrophil chemotaxis. Remember, we've seen that before when we talk about inflammation. So make sure we remember the leukotriene B4 is a neutrophil chemotaxis. And the rest of them, we have the LTC4, LTD4, and LTE4. And this guy could increase bronchial constriction, causing asthma, and they could also cause increased venular permeability. And that's why if a patient is taking medication like aspirin or NSAID, both of them could block cyclooxygenase. So by blocking cyclooxygenase, so that means your arachidonic the arachidonic substrate is going to be shunted to production of what? Leukotrienes. So you're going to have increase in leukotriene production. And that's why that could lead to what we call NSAID or aspirin-induced asthma. So that could induce asthma in those patients. So now let's talk about these arachidonic acid metabolites and their function. So like we mentioned, these prostaglandin, they are released from the phospholipid of those cells. So what are those cells? So cells like mast cell, macrophages, endothelial cell. And the enzyme there is going to be cyclooxygenase. And we have two types of them. We have the COS1 and COS2. So subspecific prostaglandins, so we have thromboxane A2, which is produced by the platelets by the help of thromboxane synthase. And like we mentioned earlier, their function is to cause platelet aggregation and vasoconstriction. We also have the prostacyclin, which is PGI2, and that's also produced by the vascular endothelial cells via what we call prostacyclin synthetase. And this, like we mentioned earlier, the function of the prostacyclin is opposite to thromboxane A2. So this will function by causing vasodilation and inhibits platelet aggregation. Next one is our PGD2, and this function to cause vasodilation, and this could increase post-capillary venous permeability, leading to edema. Just what we saw with histamine, similar function as histamine. Next is prostaglandin E2, similar function as PGD2, which causes vasodilation, and it could increase post-capillary venular permeability, leading to edema. And another thing that is unique about this PGE2 that they love acting is going to be pain and fever. So prostaglandin E2 could also work on the hypothalamus, thereby leading to what? Leading to fever. And it also mediates what? Mediates pain, just like bradykinin. Remember, prostaglandin E2 and bradykinin, both of them mediate pain. And it could also increase uterine tone. Next one there is prostaglandin F2 alpha. So this could cause contraction of the uterine smooth muscle. It could cause bronchial smooth muscle contraction. So that means that could increase the risk for asthma. And it could cause small arterial contraction. And like I mentioned earlier, very important in primary dysmenorrhea. So if you see a question on dysmenorrhea and they ask you which of these chemical mediators is implicated in it, your answer is going to be prostaglandin F2 alpha. So now, let's now focus on organ-specific functions of these mediators of this prostaglandin. So we're going to start with the blood vessel. So our prostaglandin, so the one that work on the blood vessel, so prostaglandin E2, prostacyclin, and thromboxane A2. So like we mentioned earlier, your prostacyclin causes vasodilation, decreased platelet aggregation, whereby thromboxane A2 is going to cause vasoconstriction, and that will increase platelet aggregation. And a prostaglandin E2 normally causes vasodilation. So that means, like we mentioned earlier, the prostacyclin is going to help with, is going to prevent clot formation, but thromboxane A2 is going to facilitate what? Clot formation. And that's why aspirin reversibly inhibits our cyclooxygenase in the platelet, and that's how we decrease thromboxane A2 production, thereby decreasing platelet aggregation and decrease thrombus growth. And that's why we use aspirin for somebody who's having what? Myocardial infarction. Right? And COS2 inhibitor, those one will decrease prostacyclin, and that could increase the risk for cardiovascular risk. And that's why one of the side effects of your COS2 inhibitor, like your celecoxib, is it can increase the risk of what? Cardiovascular or thrombosis, because of the decrease in prostacyclin. And that's also well tested on the exam. So moving on to the next organ, which is going to be in the lungs and the bronchial. So here we have the leukotriene prostaglandin who also work on it. So your prostacyclin, prostaglandin E2s, those one will cause bronchodilation. But remember, your leukotriene C4, D4, E4, those one normally cause what? Bronchoconstriction. And that's why, like you mentioned earlier, if somebody is taking NSAID or aspirin that is inhibiting cyclooxygenase, that will shunt those arachidonic substrates into leukotriene production, and that could lead to what? That could worsen asthma. Next is going to be CNS hypothalamus. So PGE2 normally work on the CNS hypothalamus. So that could lead to fever by raising the hypothalamic set point. So PGE2 increases fever, and it could also mediate pain, and that's why we use NSAID, acetaminophen, to reduce fever and pain, because by blocking cyclooxygenase, they will decrease prostaglandin production, thereby helping with fever and pain. Next is in the kidney. So in the kidney, we also have prostaglandin helping the kidney, helping the blood flow to the kidney. So we have the prostaglandin E2 and prostacyclin. So both of them, they cause vasodilation of the afferent arterioles. Remember, the afferent arterioles carry blood to the glomerulus. So by causing vasodilation, that means that will increase the renal blood flow. So that means you're going to have more blood in the glomerulus. And as we know, if you have more blood in the glomerulus, that's going to increase which pressure? Very good. Hydrostatic pressure. So glomerular hydrostatic pressure. And as we mentioned in the past, whenever you increase your glomerular hydrostatic pressure, that will push its fluid away, and that will be pushing it into the Bowman capsule, thereby increasing glomerular filtration rate. And this helps to maintain glomerular filtration rates during stress, particularly during hypovolemia, when there is low volume in the body, and also in heart failure. And that's why it's important not to give these patients NSAID, right? And this is why NSAID, because NSAID will decrease those prostaglandin production, and that could lead to acute kidney injury, especially in patients who are dehydrated or elderly patients. And next one is in the eye. So we have the prostaglandin F2 alpha that work in the eye. So this could increase the outflow of the aqueous humor, and that could help to decrease the intraocular pressure. And that's why we use it for what? For glaucoma. So like medication like latanoprost, those medication, or travoprost, we use them for what? For glaucoma. Next one is in the stomach, which is in the GI mucosa. So prostaglandin also works there. So we have the prostaglandin E2 and the prostacyclin. So they increase mucus production, increase bicarbonate secretion, and increase mucosa blood flow, and decrease gastric acid secretion. So they are kind of like protecting the stomach against those acid. So that's why if patient is taking NSAID, those NSAID will inhibit those prostaglandin, and then this protective barrier will not be there anymore. And that could lead to things like NSAID-induced gastritis. They could develop ulcer, and they could develop what? GI bleeding, because those vessels are going to be exposed, and they could start what? Bleeding. And that's why if somebody have NSAID-induced ulcer, we can give them medication like a prostaglandin analog, which is misoprostol, and that will help to protect the stomach. So moving on to the next one, which is going to be the immune and inflammatory cell. So under here we have prostaglandin E2, leukotriene, and lipoxin, also working with our immune inflammatory cells. So we have the prostaglandin E2, which could cause inflammation, pain, and fever. We have leukotriene B4. Remember, we said that that's a neutrophil chemotactic. So we want to invite neutrophil to that side. And then we also, the third one there is lipoxine. Remember, we mentioned that lipoxine has an anti-inflammatory property, because that could inhibit adhesion, and it could also decrease what? Neutrophil chemotactic, thereby acting as anti-inflammation. Also, on the platelet, we have thromboxane A2, which could increase platelet aggregation, causes vasoconstriction. And that's why we use aspirin to decrease the thromboxane A2 as an antiplatelet effect. And which chemical mediator function is opposite to thromboxane A2 that we saw earlier? Very good. Prostacyclin, because prostacyclin will decrease platelet aggregation, and it's going to cause vasodilation. So moving on to the uterus. So on the uterus, we have the prostaglandin E2, prostaglandin F2 alpha, and we also have prostaglandin E1. So this one increase uterine tone, increase uterine contraction. So that means this guy is going to be abortifed. So if somebody is a reproductive age, a female that's a reproductive age that looking to get pregnant, this is not going to be a medication to put them on, because this medication, they are what? Abortifacts, right? So they are teratogenic, so they could cause what? Abortion. And what are the clinical correlations, so or clinical use? So like labor induction or cervical ripening. So we can use our prostaglandin E2 analog like danoprostone, or we can use our prostaglandin E1, which is misoprostol. So that's why we use this medication for labor induction or cervical ripening. And then also in postpartum hemorrhage, especially there's decreased tone of the uterus. Then we can use things like prostaglandin F2 alpha, like carboprost. And then for dysmenorrhea, like we mentioned, prostaglandin F2 alpha is what normally causes dysmenorrhea, and that's why very good medication for dysmenorrhea is going to be NSAID, because that NSAID will decrease this prostaglandin production. Moving on to the next system, which is going to be the ductus arteriosus. Remember, in the fetal circulation, the ductus arteriosus is open, and that facilitates the shunting of blood from the pulmonary artery into the descending aorta, and that's a normal process in the fetal life. But and what keeps it open is going to be your prostaglandin E1, prostaglandin E2. And then remember, the other thing that also keep the ductus arteriosus open is the low oxygen tension. So that low oxygen also keeps it open. So and that's why if a patient is born and you still want to keep it open, maybe because they have cyanotic congenital heart disease that needs to be fixed, then you can give them prostaglandin to keep it open. But if you need to close it, then you have to give them medication that will decrease the prostaglandin. So example is going to be our NSAID like indomethacin, ibuprofen, and that will help to decrease those prostaglandin production. So moving on to the next chemical mediators, which is that come from the arachidonic pathway. We spoke about them earlier, which is going to be our leukotriene. So leukotrienes, they come from the leukocytes, and the enzyme that help to produce them is going to be our lipoxygenase. And then we mentioned leukotriene before earlier, and the function include neutrophil chemotaxis and activation of neutrophil adhesion molecules. And then we also have leukotriene C4, leukotriene D4, and E4. And then those ones could cause vasoconstriction, increase venular permeability, and they could cause bronchoconstriction, thereby leading to what? Asthma. And the last one there is going to be lipoxin, which is also produced from lipoxygenase pathway. And like I mentioned, those one have what? Anti-inflammatory property. So they inhibit neutrophil recruitment, they suppress cellular component of inflammation, and promote resolution of inflammation. And then remember, prostaglandin E2, bradykinin, they brings about pain. Remember, we mentioned that earlier. So now, what are these inhibitor of this arachidonic acid metabolism? So we have the cyclooxygenase inhibitor there, which include our NSAID, so like things like NSAID aspirin, right? And under NSAID, we have things like indomethacin, ibuprofen, naproxen. And they block the cyclooxygenase, thereby decreasing prostaglandin and thromboxane synthesis. And then remember, aspirin irreversibly inhibits that enzyme. So by irreversibly inhibiting that enzyme in your platelets, so that means that platelet is not working anymore because those enzymes are not going to work anymore. And what's the half-life of platelets? Very good, so 7 to 8 days. So that means you will need to produce new platelets for you to have a functioning enzyme. So as you know, COX-1 promotes prostaglandin, which is involved in inflammation and also physiology homeostatic function. So for instance, like what we mentioned earlier, so the renal blood flow, electrolyte balance, gastric mucosal cytoprotection, and a platelet aggregation, which is the thromboxane A2. So that's why if you have a drug that is blocking COX-1, which is a COX-1 inhibition, that means we're going to lose the GI protection. So that could lead to GI toxicity. We're going to lose the renal blood flow. So that could lead to renal effects, and that could also increase the risk for what? For bleeding. As opposed to COX-2, COX-2 is induced during inflammation, and that produces prostaglandins that involve only in inflammation. So that's why if somebody is taking a selective COX-2 inhibitor like celecoxib, so that will decrease the inflammatory prostaglandin. But the good thing about celecoxib, because it doesn't work on COX-1, is going to have a minimal effect on the gastric mucosa and also your platelets, which is why sometimes if somebody has peptic ulcer disease and there is so much pain and they want to address the pain, you can give them COX-2 inhibitor because that will not affect the gastric mucosa. But remember, the adverse effect from this is that it can lead to increased thrombotic cardiovascular events because it's decreasing prostacyclin and your thromboxane A2 is unchanged. So by decreasing the prostacyclin, so that means, remember, prostacyclin normally causes vasodilation and inhibit platelet aggregation. So that means there will now be imbalance between your prostacyclin and thromboxane A2. So now because you're having more thromboxane A2, then that will lead to vasoconstriction and increase in platelet aggregation, thereby predisposing those patients to thrombotic cardiovascular events. What about the drugs that inhibit lipoxygenase pathway? So we have the first one there, which is xylutine, which is a 5-lipoxygenase inhibitor, and that could decrease the synthesis of leukotriene production, and we could use that in the case of asthma. We also have medication that are leukotriene receptor antagonists, which include montelukast, xivalucast. And what's the mechanism of action? So those guys block our cyst leukotriene 1 receptor, and that will prevent. So even though you can produce the leukotriene, but the leukotriene will not be able to bind to those receptors, and that would decrease the effect of those leukotrienes. So this could help to improve bronchoconstriction and vascular permeability. And that's why we use those medications for somebody who have things like NSAID or aspirin-induced asthma, because by giving it to them, that will prevent those leukotriene from binding to the receptor, thereby helping with their symptoms. And then we also have the broad spectrum inhibitor, which is our glucocorticoid, which inhibits phospholipase A2, thereby decreasing production from the arachidonic pathway, and that will decrease the prostaglandin and leukotriene. And this is the most powerful anti-inflammatory drugs, because it's not only working on the arachidonic pathway, it also works in other pathways. For instance, it can decrease your interleukin 2, thereby decreasing lymphocyte proliferation. It can decrease release of chemical mediators from the inflammatory cells. It can inhibit adhesion molecule, the neutrophil adhesion molecule, thereby preventing the neutrophil from leaving the vasculature, thereby leading to neutrophilia. It can lead to sequestration and apoptosis of the eosinophil, thereby decreasing your eosinophil. It can also lead to apoptosis of the lymphocytes, thereby decreasing your lymphocytes. So this drug is a powerful anti-inflammatory drugs. And of course, side effect with chronic use. So the reason why most of the time we don't want to use it in the long run, because of the side effects. Remember, side effect can cause osteoporosis, immunosuppression, it can lead to diabetes, and many more side effects. The next drug here is fish oil or omega-3 fatty acid. So this competes with arachidonic acid. So that means there will be no substrate for the cyclooxygenase or lipoxygenase pathway, and that will decrease the production of inflammatory mediators. And this also has anti-inflammatory effects. And the next chemical mediator that we're going to be talking about is platelet-activating factor. So this platelet-activating factor is a potent phospholipid-derived inflammatory mediator, but their effects are very low, with effect at very low concentration. And where are they coming from? So they are produced from mast cell, basophil, neutrophils, macrophages, endothelial cell, platelets. And they are also derived from the cell membrane phospholipid, not the arachidonic acid. So this is different from the arachidonic acid pathway. And what are the major actions? So they could cause platelet aggregation, platelet degradation, and a thrombus formation. What about the vascular effects? So they could cause vasodilation, and they could also increase vascular permeability. But remember, histamine could also cause what? Could also cause vasodilation and increase vascular permeability. But this is more potent than histamine at a very low dose. So at a very low dose, they are very potent, even more than histamine. And they could also lead to, what about their effect on leukocytes? So leukocyte effects. So neutrophil chemotaxis and leukotriene activation. And also it will increase adhesion and molecule. Because if you remember, when we talk about our neutrophil chemotaxis, which is going to be our click P, right? Remember, one of that P there is platelet activating factor. Remember, the L there is what? The LTB4, which you saw earlier, the leukotriene, right? So those are also part of the neutrophil chemotaxis. And then make sure you watch the previous lecture whereby we talk about the neutrophil chemotaxis. So what are the other effects of this platelet activating factor? So it could cause bronchoconstriction, and it could also decrease cardiac output, which is important in shock. So as we can see, so this platelet activating factor could contribute to anaphylaxis, septic shock, acute inflammation, and their effects are dose dependent. So like we mentioned earlier, at a low dose, they're going to lead to inflammation. At a very high levels, they can lead to what? Shock-like states. So we've come to the end of today's lecture. So let's do some questions. So the first question there, a 45-year-old man with osteoarthritis takes daily NSAID for pain. Over time, it develops epigastric pain and melena. Remember, melena is a black tarry stool, which is because of the gastric acid breaking down those the hemoglobin into hematine, and that hematine is going to give this stool that black tarry appearance. And then when you see melena in this stool, it's a sign of upper GI bleeding. So which enzyme inhibition best explain these symptoms? So because this patient is taking NSAID, that will decrease what? That will decrease the production of, very good, prostaglandin, and that will prevent the that will affect the barrier of the stomach. And which of these cyclooxygenase is responsible for production of those prostaglandin E2? that protect the stomach. Very good. COX-1. And that's why if this patient who have NSAID-induced gastritis or NSAID-induced GI bleed, if they're having severe inflammation and then you need to use a medication to help with their pain, then you can use what? Selective COX-2 inhibitor, because that will not affect their stomach. So next question there, which arachidonic acid metabolite most responsible for neutrophil chemotaxis? Remember that to be our leukotriene B4. Next question, a 30-year-old asthmatic is treated with multileucas. Which mechanism best describes this drug? Remember we mentioned is going to be C. So that will prevent blocking the leukotriene receptor, preventing the leukotriene from binding to those receptors. Next question, which of the following is most likely to increase fever by acting within the hypothalamus? And the best answer is going to be prostaglandin E2. And that's why we use things like NSAID aspirin, NSAID. That's why we use things like NSAID or acetaminophen to decrease what? To decrease fever. Next question, selective inhibition of COX-2 will be expected to cause which of the following effects? Remember, like we said, if you are using selective COX-2 inhibitor, that will be decreasing your prostacyclin, but your thromboxane A2 is going to be unchanged. And because of the mismatch between both of them, because now you're having thromboxane A2, which can cause platelet aggregation and cause vasoconstriction, and you're having less of prostacyclin, which is supposed to cause vasodilation and inhibit platelet aggregation. So this is going to increase this patient's risk for thrombotic cardiovascular events. So the best answer there will be B. Next question, a 28-year-old woman with a history of asthma reports wheezing, nasal congestion. So wheezing, nasal congestion, and then sometimes they could say nasal polyps. And after taking ibuprofen for headache, she has also experienced similar reaction to aspirin in the past. Which of the following best explain this pathophysiology of her symptoms? So this patient likely experienced what we call Samta's triad. And the word Samta triad, so the first part of it is going to be asthma. So asthma is first part of it. And the next part of that triad is going to be nasal polyps or chronic rhinitis. And the last part is going to be what? Aspirin or NSAID sensitivity. So when you see this, this is what normally we see in aspirin-induced asthma or NSAID-induced asthma. And like we mentioned earlier, when you inhibit cyclooxygenase, those arachidonic substrates will be shunted to production of leukotriene. And those leukotriene, particularly leukotriene C4, D4, and E4, those ones could increase what? Bronchial constriction. So the best answer there will be B as in boy. And the last question there, a 19-year-old woman reports severe lower abdominal cramping during menstruation that starts with the onset of her period and lasts about 1 to 2 days. She has no abnormal bleeding or pelvic pain at other times. Which of the following mediators is most responsible for her symptoms? Remember, like we mentioned earlier, the best answer there will be prostaglandin F2 alpha. We've come to the end of today's lecture, guys. Please don't forget to like, subscribe, and follow us on our social media platform. Also share with your friends, and I will see you guys in the next lecture. Bye for now.